So these Square One Lunch and Learns are an opportunity to learn over the lunch hour, highlighting awareness around challenges facing many in our community who are vulnerable and without a home. Our mission for Square One community is to support and advocate for those who are facing homelessness and barriers due to substance abuse, mental health, incarceration, acquired brain injury, and other social barriers. We are wanting for people to have a sense of community and belonging. We believe in a harm reduction approach, low barrier model that supports individuals wherever they are on their journey. And I want to highlight some of our Square One community board members. So from the top, I see Noreen Edmondson. There's Noreen, and there's Lynn Kirk and Christine Boychuk. Today, that's a part of our team, and we're just, I'm so honored to be a part of this group working passionately. We are also honored today to have Andrew Love here with us to share Andrew's experience and expertise. And like, does a name get any better than Love? I just love that. I love that. Andrew Love has worked in addictions and mental health for the past 15 years as both a frontline addictions counselor and a program director, designing and delivering mental health and addiction-based services. His current role as director of the Justice Community Support Program involves working within strategic partners to target addictions and mental health barriers for those involved in the justice system. And today, Andrew is speaking on approaches to addiction recovery and harm reduction. And so will you help me welcome Andrew?
Thank you.
And so, Andrew, right now I'm going to just share.
Sure.
Make host here. There we go. Okay.
And I'm going to share with you folks a PowerPoint. So what I wanted to do is just kind of go over this harm reduction presentation that I have first, and then I wanted to leave it to open discussion. I find that that's kind of a better way of getting the information that you want, because everybody has kind of their own interests in harm reduction and addictions, and I'm an open book, and I'm willing to take on any questions, even throughout the presentation. If you have a question, just shoot it out to me. I'm not good at watching for like hands up and stuff like that. Just spout it out. That's the way the world works. So I'm going to go ahead and share my screen and run through this presentation with you folks. And then, like I said, at the end of it, we'll open it up to a Q&A. You can ask specific questions. So just give me 1 second here and I will share. No. I don't know which screen you're seeing, but.
I'm seeing a main harm reduction in Saskatchewan, and then there's a little one with next slide showing.
That's okay, hang on. I'll share.
There we are.
There we go. Okie dokie. So a little introduction to myself here. So I'm a social worker by trade and by schooling, but I use social work practice in the work that I do, but I also like understand the harms and the historical harms that social work has contributed to in dealing with primarily First Nations based population that I work with. So we do recognize that, and I try my best to correct that. I also I'm a little rough around the edges. I'm not your typical social worker. I swear a lot, and so pre-warning here. I may slip a word here or there, but it's just the nature of the work and the types of folks that I work with. I found that if I'm going and approaching people as a social worker and talking to them like that I'm not connecting with them on their level, and I'm not going to make any progress in building a relationship with the folks that I'm working with. So I often get wrapped up working with we got somebody coming in here, Kelly.
Sure. Okay, just
Kaylee.
Welcome,
Kaylee. So a little history about me. My first taste of the streets, I was working for a methadone program as a community outreach worker. And I'm going to be perfectly honest, when I took that job, it was a novelty for me. I was 20 years old. affluent white male from, the east end of Regina, and this is my first exposure to issues of poverty, addictions, crime. And at the very beginning for me, I'm like, this is entertaining. But it very quickly shifted to, oh, this is people's reality. This is the way that people are living. This is a reality for a significant amount of people. And actually, that's what kind of got me into this work in the first place. I was working there while I was completing my first degree in political science. I wanted to work as a policy developer for whatever. And those kind of lofty ideas you have in first year of university or whatever. So I finished off this degree and I went back to do social work because I wanted to work frontline with folks after my experience working with the methadone program. So I've worked in both non-governmental organizations as well as government addictions programs. So I've worked for community-based programs that offer methadone programs or harm reduction approaches. I've also worked for addiction services with the Saskatchewan Health Authority. Currently, I am the Justice Community Support Director with the Canadian Mental Health Association Saskatchewan Division. So the JCSP, as it's called, is part of a larger initiative in the province called the Serious Violent Offenders Response. And what we do is we identify folks who have had some significant challenges in staying out of prison, particularly around committing violent offenses. A lot of the times these folks are suffering from either drug addiction, they may have some mental health concerns or other barriers. So what we do is we address those barriers, we identify them provincially, address those barriers, and work together in a wraparound approach, as opposed to like a traditional model where they go see their probation officer. I drank last night. Oh, you drank last night? That's a breach of your probation. So you're breached, you're going back to jail. Our whole goal is to keep people out of jail, reduce the rate of recidivism. We know that evidence has shown that if people are surrounded with supports, that the rate of recidivism goes down. So that's what we do. We have police. It took a long time to get people on board. Police have a very structured attitude towards crime, right? You commit a crime, you pay the price, you go to jail, you do your thing. But our police that we work with are, they understand that if they're involved in programming and they breach because they're running home late, sometimes people are late. That's what happens. You know what? We're going to try again tomorrow. We take a different approach to this, and we've seen significant reductions in the rate of recidivism with some of these violent offenders. So the evidence is there. It works. It truly is a harm reduction model as well. And then undoubtedly, I'm a true Gemini, and you can take whatever you want from that. So moving on, how do I even switch this? I'm so terrible with technology. I apologize. Let's see here. So we're going to go, you guys are already talking about harm reduction. So this might not be, or this might be new to you, or it might not be, but harm reduction is an evidence-based, client-centered approach that seeks to reduce the health and social harms associated with addictions and substance use without necessarily requiring people to, stop using. So that's where people get confused all the time with addictions treatment. They're like, they think that all addictions treatment is about stopping the use of drugs. That's not true. There are some folks that unfortunately may not be able to stop because of one reason or another, maybe an unwillingness to stop. Maybe they don't have the capacity to understand that they need to stop. And sometimes the addiction is so entrenched that they might be treatment resistant. So the idea behind harm reduction is literally reducing the risk of health and social harms associated with it, both for the person that's using substances, but also the community that they're involved with. So that includes, needle exchanges, methadone programs, things like that. So again, types of programs that I just mentioned, needle and pipe exchanges, methadone and Suboxone programs. So those are specific to opiate use. As you know, there's a huge epidemic right now with the use of crystal meth, but also with the use of fentanyl, and fentanyl being present in a lot of drugs. So another type of program that's being offered too, that I don't believe I have on here, is under the safe consumption sites. Now they're doing drug testing for folks. So they'll test their drugs to see the purity. So they can find benzodiazepines and they can find fentanyl inside your drugs. And so these are safe spaces. These people are protected when they go into these safe spaces. They can present what they have, the substance that they have. It can be tested for them, and there's no obligation for them to use it at the safe consumption site either. So that just opened up actually in Regina and Saskatoon. Those became available within the past week, I believe. I just saw a news article. That's something that's been going on in Vancouver for years and years and years. And actually in the rave scene, since the 90s, drug testing kits have been around for folks that were using substances recreationally in the rave scene. Another thing is safe supply. So Vancouver is kind of the header here with safe supply. So that's literally providing people with safe doses of methadone or safe doses of opiates, cocaine, and methamphetamine. So these are lab produced, pure, uncut substances that folks can use. So again, they're not taking the risk that it's filled with toxins or, besides the drugs themselves, they're not taking a risk that that there's other things inside that, they're expecting to smoke meth, but then they have fentanyl overdose and they're not prepared for that. Treatment centers, what we have a problem with some of the treatment centers is that they believe in abstinence models solely. And again, we know that that doesn't work for everybody. So some of them don't allow the use of harm reduction medicines. Treatment centers, realistically too, in this province are about 30-day programs. And we know from evidence has showed us that in order to treat people appropriately for addictions, they need to be in 60 to 90-day programs minimum because of things like post-acute withdrawal, which happens 30, 60, 90 days after folks have stopped using drugs. They'll get the same symptoms. And so what happens is folks go in, they detox, they spent 30 days in an addictions program, then they're released, and then they hit post-acute withdrawal and they don't have the skills to deal with it. And then oftentimes they'll start using immediately after. Another thing that we have in this province is drug court. So in Regina specifically, we have the drug court, and folks, will get charges for large portions of drugs or whatever. And instead of getting sent to prison, they'll get sent to drug court where they're doing daily programming and they're participating in addictions programming and such. The other thing we have is educational programs. These are largely left to community-based organizations. There's some information out there from the Sask Health Authority, but the majority of the educational programs are coming from small underfunded organizations like Prairie Harm Reduction, or in Regina, the Neo-Watina Friendship Center. And also they're ones distributing naloxone kits and naloxone kit training. The problem with naloxone kits in Saskatchewan is a lot of them that are being distributed are the intravenous ones. So folks are expected to, under pressure, know how to draw naloxone and then inject somebody, in muscle tissue, so like a leg or the buttocks or whatever. It's very difficult to do. As a trained addictions counselor, I've used these kits and I've pricked myself while trying to fill up these kits. They're not user friendly. And the reason why we get those kits is because they're cost effective. There is an alternative way. The police carry intranasal, so just put it in the nose and spray up, and it releases it intranasally. And those kits are available. They're about $150 a piece. So they're not readily available to folks. So a lot of the people that are carrying around naloxone kits will end up using the syringes that are in there for their own drug use. And then they don't even have syringes to help save their own lives or save their friends' lives. So that's the failure of the naloxone kit program. But at the same time, that's, we're moving ahead in understanding what's needed in the community, and talks like this and educating the public are the things that are going to kind of get us in that direction, right? So, I mean, there's things there. They fall very far from being super effective and super accepted, but drugs and harm reduction in general is a hot topic that's, debated and kind of split in our community, and I'll get to that. So I wanted to highlight a couple other places that do harm reduction and do it well. So Vancouver obviously is kind of the Canadian role model of harm reduction. They've had safe consumption sites, needle exchanges, community policing initiatives, and a naloxone program in place for a significant amount of time. Before you'd go down to Hastings Street there and you'd literally be stepping over needles all over the place. They have community agencies that are going out and picking up needles and disposing of them safely. They have people actually using the needle exchange and using the safe consumption sites that are supervised by nurses. It's reduced the rate of people that are dying from overdoses. It's not reducing the rate of overdoses. That's actually going up, but it's reducing the rate of folks dying from an overdose because they're surrounded by healthcare professionals that are able to intervene. The reason I say that overdoses are going up, and that's strictly because of fentanyl. We're seeing a large increase in overdoses, and in particular in Saskatchewan, fatal overdoses because of fentanyl. Portugal is another model. So I encourage you at some point to look up the Portugal model. So they decriminalized all drugs. I'm not, again, these are things that work for their communities. These might not work for ours, but these are just sort of ways of looking at things. They have a multidisciplinary team approach to things, and they have significant amount of funding. So funding is the key thing here. The government bought in. The government said, we have an issue, we need to deal with this, so we're going to fund these institutions. So police will pick somebody up on a drug charge. What they'll do is be like, you're addicted to drugs, you're going to a treatment center. The treatment center will involve a psychiatrist, it'll involve nurses, it'll involve their family, and it'll involve any support that they can get their hands on to wrap around and support this person. And instead of going to jail for possession or use, they're going to be sent to an addictions program, usually 60 to 90 days or longer. It could be up to a year. And again, the reason why they have that is because of funding. And the reason why we don't have that is because we are very, very, very underfunded. We hear things like, we just got $1.3 million for a new addictions bed. That doesn't go very far in a year. As we know, most organizations run around the $1 million mark, and that's to barely survive and barely exist. And we have a significant population that are using substances. So here's our things that I think harm reduction should do. They should provide practical alternatives focusing on consequences of potentially harmful behaviors rather than the morality of the behavior. So, you're meeting the clients where they're at, you're meeting them where they need to be. You're not shaming somebody, you're not telling them how wrong their use is. The morality of the behavior is irrelevant. We want to look at the potentially harmfulness of the behavior. It's like, you could die. Telling people, having those conversations, not like this is bad for you. It's like, no, you will die from this. You can eventually die, whether it's an overdose, and getting comfortable saying that. Harm reduction should also accept alternatives to abstinence. In this province, we've had a lot of abstinence-based programming, and that does work. So I think the difference is that abstinence models and harm reduction models are two different things. Abstinence is looking at getting people off of substances. That's the main goal. Harm reduction doesn't have that goal. Or it has that goal, but it's not the front-running goal. The front-running goal is to reduce harm. People get that confused. So when they hear harm reduction, they're like, abstinence models work better for getting people off drugs. Like, yes, it does, 100%. AA, NA, things like that, detox. People, that's the only way, besides methadone programs, to eventually get off drugs is to abstain from them. But again, the problem is people see harm reduction as not effective because it doesn't get people off of drugs. They don't understand what the actual reason for it is. Harm reduction should also consider drug use as a health issue and a social issue with diverse determinants of health. Unfortunately, our province sees it as a crime issue. Drugs are illegal, you're doing drugs, you're committing a crime. We see in our own systems how drug addiction has been separated even from mental health. In Regina, the addiction services is a separate building than the mental health is. The drug addiction or drug treatment is held at a different building than mental health treatment is held at. We know that oftentimes a significant amount of people who are using substances also have a concurrent mental health disorder that needs to be treated at the same time. These things are separated. And again, that's because as a province and politically, we're divided on substance use. We see it as a criminal issue, not a health issue. We want to provide accessible, appropriate services that involve people who inject drugs in planning and decision-making. A lot of these decisions are being made by politicians who don't have experience in harm reduction. And a lot of the funding decisions are being made by people who don't have any involvement in addiction services whatsoever. Having people who use substances be involved in harm reduction is essential. They know what it's like. They know what's needed. We don't. As outsiders, we don't have any idea. We can make guesses. We can make pretty good guesses, but we'll never get the exact right thing. And it should really involve community and stakeholders. You need everybody involved, not just the health authority telling us what we need. We need community organizations. We need community people in there telling us, you know, this is what's happening in our community. And then give those opportunity to share the information so that people can educate each other and understand where everybody's coming from instead of being so divided. Again, a look at harm reduction in Saskatchewan. It's pretty minuscule. We got a detox, you know, Moose Jaw, you guys have Waccamaw. It's a great facility. Regina, we have the Addictions Treatment Center. Majority of the treatment facilities in the province, like I said earlier, do not allow the use of Suboxone or methadone. So I think it was Pine Lodge that didn't allow it at one point. They may now. And some of the other ones, some of the faith-based ones don't do because they run on abstinence models, and the use of those substances is substituting one substance for another, right? And I've heard that before too, people saying that, you know, with methadone, you're just replacing one substance with another. You're absolutely right, we are. But we're replacing it with something that is controlled, something that is safer, and something that eliminates the things, or is supposed to eliminate the things that come with drug use, whether that's prostitution, whether that's the sharing of needles, whether that's crime, petty crime, or major crimes that are involved with drug use. Methadone program, we have one in Regina. I'm not sure about Moose Jaw. I'm sure there is a methadone prescribing doctor in Moose Jaw, and I'm sure there's pharmacies that may dispense methadone, but I don't know about an actual like SHA program. But I saw some heads shaking there. So needle exchanges, oftentimes, like Regina, we have one at the AIDS program. And I believe that's the only one currently active. And the health authority, again, I don't believe at detox you can do a needle exchange. You can dispose of them, but you won't get clean ones there. AIDS program is one of the only ones that does it in Regina, and that's because of their connection to harm reduction. And then, of course, the naloxone program. You can go to any pharmacy and request a naloxone kit. Most of the pharmacies have them. It's a 15-minute training. You watch a video, and then that's it. But like I said, oftentimes you're getting a needle-based one. Actually, what do I have here? I have... So I'll show you quickly the difference in the kits. So this is the one that you're typically going to get. And so it has 2 syringes, some gloves, dental dam if you have to do mouth to mouth. And then it comes with these little tubs of these little things in naloxone. Sorry, I don't know which camera I have on. So these are a problem in themselves. So if you look at the top here, there's still stuff in the top here. So you got to swing it around, get all the stuff in the bottom, then you break off the tip of it. You can get cut while you're doing that, and I have every single time that I have. And then you have to take the syringe and draw it up. And so, of course, like I said, I'm not a nurse, and I pricked myself several times trying to draw it up. Another thing that, I always forget about this, and then I get it brought up when I open up the kit. These are the syringes that they're giving to folks, and this is one of the best harm reduction tools that I've ever seen in my entire life. Yet we will not provide them because they're so expensive. So these syringes, my guess, if you bought them in bulk, probably 10 cents a unit, as opposed to the other ones, they're about 1 cent a unit. But these ones, when you push down on the plunger, the actual syringe part retracts back into the needle, making it single use. What we have in this province is exceptionally high rates of HIV, and that's through intravenous drug use, and that's through the sharing of needles. If we had even just this, that could reduce the rate of folks contracting HIV in our province because they make them single use. It would also reduce the risk of these being dropped all over the neighborhood. You know, I see syringes all the time. You'll never see one like this though. They only come with the naloxone kits, and we don't give them out because they're too expensive. And I think that's terrible because this can be one of the best harm reduction tools that we could have in our toolkit. and it wouldn't be that big of a deal to order a box of them and distribute them. Again, you have to get the province on board. So the other kits that I was talking about, the good ones, super simple. Take this out, open this package, stick it up their nose, press the button, you're done. Takes 3 seconds. Where this might be a 5-minute process if you don't know what you're doing. And time is of essence when somebody's overdosing. So that just shows you kind of where we're at. You know, we have things in place for harm reduction. Is it enough? No, not at all. You know, are we grateful to have it? Of course, but at the same time, we shouldn't settle for subpar, especially when it deals with people's lives. So I just wanted to show you, this is a little outdated data, but drug toxicity deaths in Saskatchewan over the years. In the first quarter alone of 2020, there was more than there was in all of 2010. And this is again, because once you see around the 2015, 2016, 2017 mark, that's when fentanyl started coming into play. Fentanyl has been around and people have been using it, but now it's so readily available and so cheap. They're buying it from China. It comes in giant things of it. People are also using fentanyl like exclusively. It's not just in their drugs. They're shooting fentanyl, they're smoking it, they're snorting it. They're actively seeking out the fentanyl, which is so insane to me. When I was at the Addictions Treatment Center, that was the first time that I found out that people were actually actively seeking out fentanyl to use. If you look at the crime stats recently, a lot of the people that are getting arrested for drug charges, fentanyl will be in there. You know, trafficking fentanyl, it's huge. You know, the opiate epidemic is as big as the meth epidemic, and they go hand in hand. So these are just a couple of the Regina-based ones that I know of, and Saskatoon-based harm reduction programs. And good place to get your information from is Saskatchewan Health Authority has the methadone program, and it gives you a good understanding of what methadone is and how it works. Parliament Harm Reduction, that's in Regina here. It's a private methadone clinic, and that's where I worked the first time around. They do great work. They offer rides to people. They get them connected to the food bank. They do things other than just distribute methadone, which is what you need to do. You need to be a community-based organization that provides other services, not just methadone. That's not enough for folks coming in, because they can go to any pharmacy and do that. It's an opportunity to get people engaged in other things and other services. AIDS Program South Saskatchewan, which has now changed their name to Prairie Harm Reduction, is a huge advocate for harm reduction in Saskatchewan. I think the thing though is that they've really been trying to appeal to a younger crowd, and I think it's isolated or sort of may have turned some older folks away from it. You know, they're using like young language and like memes and stuff to kind of get their message across. But when I think about it, realistically, the people that are going to be, you know, donating to your campaign and donating to your funding aren't going to be 20-year-olds, you know, that can't afford to do it. It's going to be older folks, and that education needs to be geared towards funders. Really, it's good to educate the youth, and I think that they're doing a good job of educating them. But I think that there's a gap there in educating the, you know, our voting folks. You know, our seniors and things like that, people that aren't exposed to harm reduction, and that have been told from the get-go that drugs are bad, drug users are bad, and, you know, the only way to do it is to stop using. And I think there's quite a few folks like that in our province. The other one was Space QTY. So that's the trans organization for youth in Regina. So I was facilitating a trans and queer addictions talking circle. It's stopped right now, but as soon as they're back in action, we'll be doing it again. And so that's for any youth that identify as queer or trans, or sort of anywhere on the queer spectrum, to come in any form of sobriety. So they might be even thinking about sobriety. You're welcome to come there. You might have 15 years of sobriety. You're welcome to come there. And it's just to talk around addictions and things that affect folks. We've seen that there's quite a bit of drug addiction and use within that community, and a huge lack of resources available to those folks. So here are my problems with harm reduction. Again, attitudes in Saskatchewan towards harm reduction are split. We're not on the same page. You know, it'll be within your own family. I have conversations about this with my parents all the time. Well, people are using drugs. That's what they chose to do. But at the same time, they didn't realize, you know, again, from my personal experience, I have been a substance user. You know, I'm what they call a cross addict. So when I was younger, it was like doing drugs, and then, you know, I get a little bit older. Now I'm drinking. And then I get a little bit older from there, and then I move on to gambling. So I know that I'm an addict for life, and the only thing that works for me is an abstinence model. And so that's what I have used to keep myself safe and sober for, you know, the past 20 years. But not everybody is aware of that. And even within family models that have witnessed this and have been involved with or have had children that are involved in substance use or anything like that, there's still split in there. And again, it's because we've been just drilled that substance use is wrong. It's bad, and the only way to stop it is to stop doing it. Harm reduction's like a lofty socialist idea of how things work, but it really isn't. Saskatchewan's focus of harm reduction is reducing the extremely high numbers of folks infected with HIV, but it still falls short of addressing a number of the other factors. And so I say that because all of the harm reduction programs started out of HIV and AIDS awareness and public health outcries, because we did have such high HIV rates. It wasn't about the drug use, it was about the transmission of HIV. That's still a focus of things, but I think it's getting better on focusing on the actual epidemic of like all of the other things, the social thing, the poverty. You know, oftentimes folks have less access to health because of stigma surrounding their drug use. You know, I've seen people go to the hospital and be like, I'm sick, I'm really sick right now, you know, I'm dope sick, I need to get in here. They're like, oh, that's a detox problem. Or they show up to the hospital and they have active psychosis from drug use. And the hospital says, go to detox. That's a detox problem, not a mental health problem. So we find a lot of barriers within the health system themselves because they haven't shifted their minds to a harm reduction model. They say they have, and they've started making things available like the naloxone kits, but realistically, the funding is inadequate. We don't have buy-in from our provincial government. We just don't. You know, whether it's this government or the government before them, nobody's invested any kind of real money. They've put it in kind of shut up money, just enough to keep people kind of afloat, but they haven't made a real investment in harm reduction. Again, that's because they view it as an issue of crime, not as an issue of health. And then problems funding for community programs, and that stems from the government. We need core funding. People are relying on these year-to-year funding streams that may not be available from one year to the next, and trying to hire qualified folks to work with people is nearly impossible when you can't guarantee that they're going to have a job next year. People don't want that. They want the stability. These programs are not stable. They rely on this kind of ragtag funding, and it's just not going to work. A lot of them will fold and a new one will start up. We've seen it so many times. There's so many community organizations that come and go because of that. And that's just the lack of investment in the people by our government. And again, no slight to, you know, the Saskatchewan Party or whoever. This has been our government historically, whoever's in power. Because again, as a community, we're split on the idea of harm reduction, and we're split on the idea that that drug addiction is a mental health concern and not a criminal concern. So how can we help? One of the big things is advocacy, having groups of folks come together and advocate for better services. That includes folks that are using substances, folks that have, you know, loved ones that are using substances, recovering addicts, people that work with folks that have addictions issues. Another thing is community partnerships, getting together at those tables and having a strategy. I know a lot of people have tried these wraparound approaches and things like that, but you really, like, the idea shouldn't be around developing programming. It should be around advocacy, because a lot of people get wrapped up in, we need funding to make this thing work. And again, you'll get a little bit of funding and it'll never work. What you need is to get together all together and be like, you really need to block fund things and have support from other people. Like, you know, CMHA, we don't have an vested interest in addictions, but it's a big part of what we do, right? So we come to the table with addictions people, be like, hey, you know, we're all overwhelmed. We need you to support them. We need you to support addictions, because it really affects the work that we do. And we like to think that we do, you know, good work here, but it is being affected by the fact that we're dealing with things that need to be dealt with from other organizations. We can't silo services either. People will try to do that. That's why, again, we don't take on very much addictions, because you can't take on both addictions and mental health, and housing, and, you know, food security, and all these things. Siloing services, just, it's a disservice to the folks that we're helping. Fundraising, again, we shouldn't have to rely on fundraising, but it's a big part of what we all do. Just again, like finding people that are like-minded, and finding activities that are going to draw folks in, to be able to deliver that message. I always like to include somebody from the community that's, you know, maybe working with the organization without violating, of course, their confidentiality. Somebody that's maybe been successful in obtaining services to come and speak to the you know, significance of their experience working with an organization and how it could have been better with more funding, or how funding this organization is a benefit to the community by seeing those success stories. And then education initiatives. I know we all have that, and everybody's doing a good job of that. That for me is more of our government educating our like general population, and that comes from us advocating to the government to do that.